Hello, welcome everybody. Let's wait for a few seconds while everybody is joining. If you would like to write down your name and the country where you're joining us from today, that would be wonderful. Okay, let me have a look. Who do we have here? No one yet? Okay, Patricia from Italy. Thank you, Patricia. Sophie Turner from Netherlands. Eva from Belgium. Jose from Belgium as well. Andrew from Ireland. Great. Thank you so much for connecting today. And welcome to this Eurordis Mental Health and Wellbeing webinar. I'm really pleased to have you all here today, and I have a special thank you for our speakers for the session. Thank you. Today's topic is it's a very important topic for our community, is how to deliver a diagnosis. Receiving a diagnosis can be a life-changing experience. It brings the end of uncertainty in some ways, but it can also bring new worries, fears, and also a stress of the unknown. The way this diagnosis is communicated deeply affect people living with a rare condition and their families. If it's given with empathy, it can bring the support and the empowerment for families to face the challenges they will have ahead. But if it's done poorly, it will increase the emotional pain and damage. Today's session is being structured in this way. We will have a set of presentations. We have invited 3 ERNs, European Reference Networks, Cranio and Vasker, that are leading projects in order to promote the awareness of how to improve the delivery of a diagnosis. And after their presentations, after each of these groups, there will be a short time for all of you to ask questions to the presenters. If for whatever reason we run out of time, you're very welcome to still write down your questions, and we will respond them either later on in the webinar or at the end of the session. After the presentations, we will have a panel discussion. We will explore ideas to minimize the impact on mental health of the moment of delivering a diagnosis, and also how to add support at this point this critical moment. After the panel discussion, there will be quite a few time for questions and answers. So all of you are invited to let us know your comments, questions. We will address those to all the speakers and the panelists. And we will finalize the session with some closing remarks. But now, before we start, I would like to thank you all again for your continuous commitment and for attending this session today. And I hope that this session will inspire us all and help us raise awareness on this topic, and also on the need to receive mental health support at this critical moment. So I would like now to give the word to Catherine Claremont and Caroline Werner. Caroline is a communications officer in ERNI, and she will share with us a serious game they have developed in order to raise awareness on how to deliver a diagnosis. And Catherine Claremont she is the head of the ophthalmology department at the Rothschild Foundation Hospital, and she will help us. She will share with us some real cases, good practices on how to deliver a diagnosis. So whenever you're ready.
Yes. So I can I have my slides?
Sure. The floor is
Thank
yours.
you. Thank you for your presentation. Thank you for inviting me to this webinar. So I have to share the screen or not?
Yes, you need to
yes.
share the screen.
Yes. But the presentation is I have no my presentation. You
want me to do it?
Yes.
Okay.
It will be better.
Okay, no problem.
No problem. So okay, thank you. So thank you. So as previously said, I'm ophthalmologist, and I'm specialized in neuro-ophthalmology, so in rare disease and rare neuro-ophthalmological disease of the optic nerve. But in the center of the Rothschild Foundation and the 1520, there is also a great number of patients with retinal disease. Next slide, please. So next, the patients with a rare eye disease, retinal optic nerve, are of course visually impaired, and some of them are blind. And you can see in the screen the impression of the patients about their vision. You can see the first who said it's like being walled up alive. So a very anxious patient. Like when you have a very hot shower and there is a thick mist in the room, you see nothing. You think living in a pixelated world. And the last one with a very small visual field said, I see the world through a keyhole. So of course, this situation is very worrying, and the patients are anxious. The delivering of the diagnosis, the name of the disease, is therefore a time of great anxiety for them and for their family. Next, for the patient, there is a fear of the moment, and there is a feeling of isolation, some kind of injustice. And some patients are angry, a fear of the future because they think that they will be blind. And for the family, there is a feeling of culpability and also a fear of not being able to manage the child, not the brother, in the future. Next, so I'm going to present first a survey of patients with Leber hereditary optic neuropathy, who tell us by phone how their experience their disease, and how they experience the moment of the announcement of the diagnosis. And you can see here in red that 4 of these 12 patients had no explanation of the future, or even contradictory explanation. For one patient, the ophthalmologist only said the name of the disease. One patient said it was so sudden, at the same time I was active, so I didn't worry about it. I figured it would pass. And 2 patients had the announcement of the diagnosis by phone. Next. And this is the word of a woman I met 3 years after the diagnosis of Leber hereditary optic neuropathy was given. We must know that this rare disease is a very brutal one, and there is a very sudden loss of vision, binocular loss of vision, or most of the patients are blind. And the only words that the doctor, the ophthalmologist, said that it's Leber, we can do anything here, and you can go to Monteclair. Monteclair is the name of the Center of Rehabilitation for Low Vision. And this woman wrote Leber and Monteclair, two pretty words that resonate to mark my entry in the visual impairment. Leber is the name of the disease, a part of my family story. It's called LOM, mutation 1178. I discovered its existence the day my brother declared it. I was 11, he was 14. Then I experienced it at the age of 20. From that moment, an extraordinary turmoil towards me, a deep emptiness that slowly turned into my self-anger, hatred and rage at being robbed of a part of myself. No more talk of the future. It was all over, and I hadn't even turned 20. So no explanation, no empathy for the patient. And this patient, many years after, wrote his pain and his anger for this delivering of the diagnosis. Next slide. The second point is a book written by one of my patients. The name of the book is You'll Never Sin Again. This patient is a special one because first his father is ophthalmologist, and he knows the family story. However, he sent his son to the emergency department of ophthalmology of the Rothschild Foundation when his son lost her vision. And this is the first visit of this young man in the emergency department. And he wrote that, I saw myself saying, my cousin suffers from Leber disease, which caused him to lose his eyesight at the age of 20. Then the doctor, the two white coats, suddenly turn around. How? I caught in the slight widening of his eyes the expression of one who understands without letting anything show. The tension in the room has risen too much. I stammer, what's going on? And they say, you probably have Leber's disease. So this patient had a diagnosis of Leber, and only 1 week after, he goes to my clinic. Next slide. And then I thought, probably I was wrong, that I have to explain with many details the disease, the course, the heredity, the treatment, and the support, of course, for the patient. I thought at this moment that I was empathic, but in his book of what he feels at this time is the comparison with a boxing match when he takes a blow with any announcement. He wrote, the loss of vision in one eye, one blow, the second eye, a second blow, and the future, a third blow. So he was very shocked by this very detailed explanation of the disease. And his conclusion is, okay, so I'm going to lose my sight and become a visually impaired person. That wasn't plain, not at all, in my life plans. I already feel that I'm alone with my question that no one will be able to answer. I'm cornered by a diagnosis that leaves me no hope of remission, and the time has begun to crumble. So even with delivering a diagnosis with empathy, but probably I was wrong because I gave too more details, and at the same time, it was very difficult for him. And so his patient was treated after with gene therapy, and I built a bond of trust with him. He escapes his job and goes well with his family. We talk by phone, and I must admit that when I read his account of the diagnosis, I was surprised because it wasn't my words, but no matter. That's how we felt. And probably I was wrong to do like that. Next. So in conclusion, the next slide, the diagnosis of a rare disease is a difficult milestone for the patient and his family. And we can see by these words that it's a very crucial moment and really a milestone in the story of the patient. It's not the next time for the patient, but it's very difficult. And it's probably also a complicated time for the physician. So my conclusion is that there is no good way to deliver bad news, but of course, tools are available to help the practitioners. And I give the next now, it's Caroline who will explain the serious game of MI. Thank you.
Thank you.
Yes, thank you, Catherine. So good afternoon. I'm Caroline Werner-Riberg. I'm the communication officer of both the French network ScienceGen and the European network ENI. And that are reference networks dedicated to rare sensory diseases. So you've just heard from Dr. Vignal some of the situation reported by patients. But in our work, we also have feedbacks from doctors in our networks. And some of them have had to deal with patients in denial, sometimes with a partner who thinks he knows better, or children who make a lot of noise. Sometimes the doctors don't even have a diagnosis to give. So these are some of the challenging of announcing a diagnosis for both patients and doctors. So we realized that the diagnosis is an aspect of a doctor's profession that is often overlooked in medical training. Learning often occurs on the job, observing more experienced colleagues, but this isn't always ideal. So we set out to create a training tool that is engaging, effective, and flexible. Yes, and its name is ADOC, and it's a serious game designed to provide practical training in delivering diagnosis of rare diseases. It was developed in collaboration with medical experts, patient associations, and psychologists. ADOC offers a unique learning experience. So the game contains 15 short scenes in which players can assume the role of a doctor, navigating through various challenging across 3 difficulty levels. A gauge allows you to track your scores, increasing according to good practices and empathy. Moreover, the game features professional voice acting, adding an immersive element. To promote the game, we did a creative communication campaign, including a teaser featuring in the French version the French voice of Dr. House. Additionally, we organized a competition for healthcare professionals with some funny prizes to win. Since its launch in spring 2023, ADOC has seen over 600 players with positive feedbacks and a rating of 4.8 out of 5. It has also successfully reached out our target audience of healthcare professionals, both senior and junior. In conclusion, ADOC represents a collaborative effort to address a crucial aspect of medical education. It has been a privilege to work with diverse medical professionals, patient associations, and production partners to bring this innovative tool to life. The game is now available online on tablets, smartphone, or computer devices, and we are very happy that we could diffuse it in French and in English. So please feel free to explore the game through the provided link here, or next slide, on the QR code here. So thank you for your attention, and your turn to play. You've got 1 hour.
Thank you so much, Caroline and Catherine. We are now going to listen to Ear and Cranial. Representing Ear and Cranial, we have Gareth Davis, Executive Director and Founder Member of the European Cleft Organization, and Marizela Kliajic, Clinical Psychologist, clinical psychologist that is going to talk about a tool on psychoeducation. The floor is yours.
Hello, I'm very pleased to be able to present today. I think this will be a really useful session for everyone. So I'll move straight on. I'm going to be talking about some user experiences. I'm going to be talking about the need, some survey results that we did a few years ago. Be talking about, actually, it's not just a point in time, it's not just a diagnosis, but an entire support system has to be in place. And finally, an example that of an action we took as an NGO, as a charity, back in the UK 20 years ago, which was actually very effective. So a very practical approach. But yeah, next slide, please. So this is, we're part of a European project called the Early Cleft Care Project, which was developing training materials for neonatal care for cleft lip and palate. A lot of babies born with clefts, the diagnosis happens before birth, but not a complete diagnosis. It's usually just a cleft of the lip that's discovered. As part of the background for developing the training material, we developed a survey covering various topics, but one of the topics we covered was experiences of diagnosis, antenatal diagnosis. And we had 94 respondents, so it was quite comprehensive from 5 countries. So it's a real across Europe study. So next slide, please.
Yes.
That's all right. So the question, understanding the diagnosis. I'll explain the figures because they're a little bit confusing at first glance. Basically, the higher the percentage, the more the respondent agreed with the question. So you understood what you were told about the diagnosis. And actually, we only have about a third in that diagram of people who said they felt they knew more or less and understood the diagnosis. You've got about 2/3 who didn't really understand, and actually 20%, a fifth, didn't understand anything about the diagnosis. So given that when you're having antenatal diagnosis, there are sometimes options given to you about termination, we felt that this is really a very difficult area and needs to be improved considerably. So the next slide, please. And we actually asked about the level of information, the amount of information given. And in this diagram, we can see that a lot of people, but less than half, thought there was enough information. But the same number thought there was too little information given. They couldn't really understand what was going on. And in fact, 5% had none, and 5% had too much. I think there is a tendency, we heard from the last presenter about people worry about giving too much information all in one go because it can be shocking. But this diagram at least indicates that only 5% of this survey group thought they had too much information. So that's quite an interesting remark. So a summary of that, of the results really is nearly half felt they were given too little information. 15% felt they didn't really understand the diagnosis and what it meant. A lot of people said the information was too technical, too difficult to understand. And 18 of the 94 respondents said they weren't given any opportunity to ask questions at all. And so any concerns, worries, issues, they weren't able to ask on the spot. And there's reasons for that. A lot of it's to do with the time that's given over to this type of diagnosis. And what one parent's example was, when the child was born, all the essential information we got were not from specialists, but from our relatives, a non-formal Facebook group, and other people who had experience. So they felt they weren't getting the information from where it should be coming. So next slide, please. And this is the point I made at the beginning. It's not about the person delivering the news. It's actually, what have you got behind that? What's the referral mechanisms? Do they know? Does a midwife know who to refer to? Does a nurse know in a pediatric unit what comes next? Do they have any general background knowledge? And if they don't, because they've never come across this condition before, then they must have access to somewhere in the hospital or birthing unit where they can find that information quickly, written information. And there needs to be better communication with, in my sphere, with gynecologists, obstetricians, neonatologists, nurses and midwives, as well as allied professionals such as social workers. So next slide, I'll give you an example of what we tried to do. Another organization worked for the Cleft Lip and Palate Association in the UK. And we had a lot of people contacting us saying They were devastated after being given a diagnosis. There were sometimes cases of the wrong diagnosis, being diagnosed with having a cleft lip and palate, whereas in fact it's just a cleft lip. Antenatally, poor communication around breaking the news, parents being steered towards termination simply because the person doing the scan would say your baby has a fecal abnormality, it's a cleft lip and palate, and you can terminate if you wish. That was what was said in one particular unit on a regular basis. Delays confirming diagnosis. So someone suspects they see something on a screen, but they don't refer to someone higher up the ladder, and people have to wait a week worrying and wondering or more, and referrals to specialists not happening in a timely manner. So next slide. So as a means of trying to put this situation right, as an NGO, I actually addressed a national conference of obstetrics and gynecology, and they said, well, can you tell us, we're the specialists, but you as a charity, can you tell us what we should be doing better? So the result of that was that us, an NGO, teamed up with a specialist unit, fecal medicine unit, and together we wrote a booklet called A Guide for Sonographers to try and address the misinformation. And between us, we actually raised funds, quite a lot of money, to make sure it was available in every fecal medicine unit in the UK. So next slide. And this is my last slide. It's basically, this is what we were trying to correct. People were making wrong assumptions about what cleft lip and palate is, what it's not, making poor examinations because they don't understand what they see on the screen. The booklet explained how to see a cleft. It actually explained how to describe what a cleft is, not just to the patient and the family, but also to other clinicians. There was a whole section on breaking the news, talking to parents what to say and what not to say. There was a big section on what not to say, and what else to look for. Is there an associated condition, this kind of thing? Unlikely, but sometimes there is. And then terminology, just a list of what the right terminology is. And I wasn't in a position, I left the charity to actually see what the impact of this booklet was, but I was very proud of the effort we made, and I was even more proud of the fact that it was us as an NGO, a charity, we were being asked to put the situation right that we felt initially should have been the responsibility of the clinicians. So it was a good partnership collaboration. And now I'll move on to my colleague, Marizella, who's going to talk to you about other aspects of delivering a diagnosis to do with psychology.
Thank you, Gareth.
Yes, thank you, Gareth. Thank you for giving me the opportunity to be part of this very important webinar. As Concha mentioned in the beginning, I'm a clinical psychologist based in Gothenburg, Sweden, but I'm also the co-lead of our psychologist group in the Ear and Cranio. And Ear and Cranio is the European reference network for rare and/or complex craniofacial conditions, ear, nose, throat, and ENT diagnosis. So it's basically craniofacial conditions that affects the skull and the face. There is a lot to say about today's topic, and my experience is that this topic is also very, very much relevant when I meet patients in my clinical practice. I won't be able to bring too many aspects during this short presentation, but I would like to mention a few. One aspect of communicating a diagnosis in the setting where I work with patients with craniofacial conditions is the challenge of what words to use when we talk about the diagnosis. Medical terms that have been used, such as malformations or anomalies, are stigmatizing. So finding the appropriate words that are also patient approved is important, since stigmatizing words, they close the possibility to talk about the diagnosis. And not many people feel comfortable talking about having a malformation or describing themselves with such words. Another aspect is this on
Sorry,
how you.
just to interrupt. Sorry.
Sorry.
Are you going through the slides, because at the moment it's just not in presentation mode, and you
Oh,
haven't
okay,
moved
sorry.
through them. So I just wanted to flag that with you in
Okay,
case you
what
were
should-
on another side. So I
I'm
think,
on an introduction, and
yeah,
where
you were
do
still on
exit?
slide 1.
Oh, I'm sorry.
It's fine.
So,
If you stop sharing, then share again. Maybe that will correct it.
okay, great that you interrupted me. Let's see. There's probably something about the let's see. Oh, I need some help. I think I need some support because I won't.
So I think if you just share your screen how you did before, you don't need to do presentation mode, but just click on the slides on the left-hand side, and that should move the main one.
Okay.
Unless, Concha, we've got the presentation from Mara.
Yeah, maybe it's better if Concha shares it, and I can just say next.
Okay.
So sorry.
No problem.
It's absolutely fine.
Okay, am I in the right?
Yes, so you can take next on that one. So that was what I was talking about. One aspect is this with what words we use, and the other was the how do you deliver rare diagnosis with many uncertainties. Next, please. So there are many challenges when delivering a diagnosis with uncertainty. There might be, you as a doctor, for instance, or a healthcare professional, when you have a rare diagnosis that you are supposed to know much about, but there is limited evidence in the literature about it, and you might have only met a few patients, but you're still expected to be the expert. So that is a challenge. Next, please. So the question is, how do you as a healthcare professional compensate not knowing, but still being the expert in the field? And I do believe that we who work in the healthcare still need to take that responsibility of that uncertainty for our patients. And one way of doing that is that we could inform what we know. We could suggest and provide contact with other families or patients with the same rare diagnosis. We can inform about available resources or patient organizations. We could also work on being available and giving our patients reassurance that even if we can't give you an answer today or a prognosis, we are still working towards it. Another way of taking responsibility of this uncertainty is that we could plan research projects and involve patients in the planning to make sure that we focus on trying by research find answers to questions that are valuable and important to the patients. Next, please. And then I would like to mention the power of psychoeducation. So psychoeducation is a type of intervention that comes from the cognitive behavioral therapy, but it could be used to educate patients about their diagnosis and expected course of treatment, including any potential risk they expect. So you don't need to be a psychologist to use psychoeducation, but you could educate yourself in how to psychologically deliver medical information. And I just want to give an example. There was, I had a colleague of mine, she's a surgeon, and we had a visiting surgeon from another country, and she was introducing me. So this is our psychologist in our team. And well, you know, when we surgeons talk our surgeon language, Marizella, she talks the human language. And what she was actually referring to is, I think about how you communicate with patients so that patients do understand. But I mean, you don't have to be, as I mentioned, a psychologist to do this. You could be anyone using this. And the power of psychoeducation is when you do that, when you explain how things work, what is expected, that is one way of giving back control to your patients, because living with uncertainty gives a sense of losing control. And when we feel that we lose control, we suffer as human beings. Next slide, please. Just to end, I would like to mention a few projects that we have in the ERA and Cranio. Face Me project is an art project that tries to answer the questions: how can we as doctors and healthcare providers be an even better guide for our patients by seeing every aspect of their lives and not just the physical part, and by showing more of ourselves as human beings. And if you're interested to see the result of this project, you can scan the code there. We're also working on developing communication tools for parents in how to talk about their diagnosis with their child, because we believe that it's important to start early on talking about the diagnosis. And then we finally have also a project that we work on. It's about how to involve children by adapting language to child's age and maturity at hospitals visits. Thank you so much, and I apologize again for the technical inconvenience.
No problem at all, Marisela. Thank you so much, and thank you, Gareth, both for your presentations. We are now going to ERM Baskern. Anne-Mette Redal, she's a clinical psychologist, and Elizabeth Lizak, child psychiatrist, will work us through the psychology working group they are running.
Yes, I would like to start out first. And if you, Elizabeth and I are representing our group, and we are going to head to Paris today to join all the others for 2 working days the next coming days. So we are both very grateful that we were invited to this webinar. It's a very important topic, and it's so nice to see that lots of people across Europe are interested in the same things. If you go to the next slide, please. Yeah, I'll just say my name is Anne Bredal, and I have the honor of being chair of the psychological group in Vascan. And my whole career, I've been working with somatic illnesses. And for the last 12 years, I've solely worked with rare diagnosis. And I also have a rare diagnosis myself, which is also very useful when understanding some of the challenges that the patients we are trying to assist are facing. Next, please. I'd like to present our psychology working group in Vascan. Just very briefly say how we begin, who we are, how we work, and what we have done so far. And when we get to the done so far, Elizabeth will take over and continue. Next, please. As we all know, there's a limited knowledge according to rare diagnosis, but there's even less knowledge when it comes to psychological issues and rare diagnosis. And we were so fortunate that in October, the Vascan annual conference invited people that were interested in this topic to join their conference, which has traditionally been for medical doctors only. And what they were asking was they know a lot about the medical stuff, but they need assistance in improving how to deal with patients in a better.
Ned, you just muted yourself.
Sorry. And on the meeting last year, we formed a group that has then been working since then. Next, please. And we are a group of 31 psychologists, psychotherapists, psychiatrists, and also very important EPACs who have special interest for this area. And we are participants from 10 different countries, and we work on different resource center and patient organization and hospitals all over Europe. And we work with rare diagnosis within the Vascan group, but with different ones. Next, please. And so far we have made a survey according to trying to map out what kind of psychological support are there at the moment at the centers of the VASCAN members. And we have also made a survey trying to understand how the psychologists and psychotherapists are being used differently in different European countries, because we realized we were quite confused about what training did people have. And that's quite nice to know when you work together across borders. And then we are trying, as the rest of you, to collect and discuss resources that already exist and which one are needed. And that's why I think it's extremely important that we work together also in the different RINs, because I think that we have more in common that differ us. I think there's a lot of special things in medical terms, but when it comes to the psychological, I think we can learn a lot from each other, so we don't sit and invent the same products, and we can learn from what everybody have tried that worked. Next one, please. And then recently, a month ago, we had a summer school. First, we had we were invited to join an online summer school for medical students and medical doctors. And we were invited to join in 2 sessions. So we had one session on patient therapeutic education, and we had one session on different areas within psychology. And you can have the slides to read the content later, but we are lots of people working on this. Next slide, please. And then lately we had the summer school in Paris, which are the same 60 participants, which is from, I think it was 26 different countries in Europe that joined this summer school, first online and then on site. And our objective was to help them develop better communication skills. And knowing that they have been sitting looking at PowerPoints for 5 days from early in the morning till late in the evening, we decided that they needed some hands-on. And that was why we decided to learn through role play. Next slide, please. And we were very well received by the participants. They were extremely eager. And we have already been invited back for next summer school in September. And it was really, really interesting. But it was what also was a bit worrying was these newly educated doctors and students in the last year. Many of them reported that they had no communication training in their studies. And here I think I will send it to Elisabeth so you can continue.
Yes, hello. I don't have any slide. I send them to you because I changed my computer and the old one is out of order and I couldn't put everything in the new one. But I think I can send them to you later on if you want. Okay. Well, yes, I am Elisabeth Lizac, and here I am as an representative of patient organization. I am a child psychiatrist in another life. Yeah, we had a summer school, and the last half day on Saturday morning, we had a role play with the students. We were 7 people, professionals and also representative of patient organization. And we made 7 groups with the students. We asked in each group one student to play the role of the doctor, one to play the role of the patient, or we also imagine a role play with a teenager, for example, and the parent. So we had 2 students, one being the teenager and one the parent. But we didn't know the students what will be the scenarios before they decided to be the doctor or the patient. And I think that was really important. Then we told them the scenario, and we made in the morning 3 role plays. They really got involved in this, and I think it was an opportunity for them to feel how it is to give a bad news and how it is to receive it. Because, of course, it's a bad news giving from human to other human, and we have to do with the limits and the qualities of humanity. And also the professional can be very uncomfortable to do the announcement and can be very anxious and do very wrong things giving the announcement. I agree completely with Catherine Vidal, who said there is no good way to give such an announcement. I think there are ways that are worse than others, but anyway, it's a bad news. And at the end, after each role play, we exchange a few minutes with the students, and it was very interesting to hear how they were, they felt what was going on with the announcement and with hearing the bad news, and how, for example, when it was a bad news for a teenager, how the teenager tried to do as if nothing happened, tried not to hear anything, and to try to go on living the life without hearing anything. I think it was a very yes, a very important place in the summer school for these students. That's all. And I'll send you the as soon as I get them, I'll send them to you. The slides.
No problem. Okay, so thank you so much for your presentations. Now I'm going to hand over to Matt. He's going to.
Just before Concha,
Okay.
I think there was a few questions in the chat, and I just wanted to cover them off. So we were asked about whether the video of this will be shared, and it will be. The event isn't, we don't get a certificate for, but maybe we should look at that in the future and develop more of a formal course on how to deliver a diagnosis. And there was, I think some of the stuff really resonated. There was a question from Lucy, I think. I think it's to Caroline. The presentation around the serious game was presented at ECRD. Is it possible to adapt this serious game to other types of audiences?
Yes, it could be possible. It's just a question of money. Like always, it's a big budget to translate such a tool in other languages. But it is possible if we have enough, if you have a good audience for one language. And so please contact us, ENI. You have the address on the website of ENI. You can contact us and we can discuss the possibility to have another language.
Great. And Lucy, it's great that you're online, and maybe we come to you later on at the end after the panel discussion about what Medics for Rare Diseases are doing around training around this important topic. But we're going to move to a panel discussion, and I put my timer on so we have time for questions from everyone. So please, in the panel discussion, there could be some something you want to ask, write it down in the chat. Concha can monitor the chat if that's okay, Concha. And we can open the mic in about 15-20 minutes. Going into the panel discussion, I just want to really commend and recognize ERNI, ERN Cranio, and Vascern. Of all the ERNs, I think you're the only ones I know which is really stepping forward into this space and trying to identify ways to improve how communication between clinicians and patients are. And it's great that you're showcasing that and prioritizing that is important. I know we've got 2 other ERNs and we've got on our panel. So I'd like to invite it will be Andre Reitman, who's a psychologist from Ernica, who'll be on the panel, so sharing the views of another ERN. Sarah Talarasco, a clinician and researcher from Reconnect. We'll have Gareth Davis from European Cleft Organisation joining the panel from the patient perspective, and my colleague Gucci from Eurodis, which you all will know. I think, Concha, you very kindly showed a little poll, didn't you? Can we launch that poll before the panel? It would be great to find out the first question, how people who are participating in the webinar, how would you rate the diagnosis you were given or one given to your the ones you love? You can score 0 to 5. I think 0 being very, very poor and 5 excellent. And maybe then when we come to the panel, we can share the results and we can ask the panel their reactions to that, because it's quite surprising hearing from Gareth, from the cleft community, from the rare eye community around the challenges which you face. But it'd be nice to get the views from people online. So while that's running, Concha, is that okay? We'll just give it another another couple of minutes. If you can pin the panel so we can see them all together. You are becoming a technical whiz if that's possible. No. Okay, can you stop sharing and then I can see them then. Let's see whether I can do it. Pin. Let's find Sarah and Gareth. Pin. I'm going to pin you all so I can see you. And Gareth. Okay, so now I see the panel. I don't know whether everyone else can, but you can pin them. That's a very good technique. So thank you very much for you guys for being willing to come and talk about this. When we extended the invitation, you all jumped at the opportunity. So it resonates with all of you. I wanted to, before we get the results, I wanted to ask maybe Gareth and Guchin, delivering a diagnosis is life-changing and lifelong. It's profound. It impacts on everyone in the family. When it's handled well in an unrushed way, it can really empower individuals to step forward, to take on the challenge which this brings. But is that reality a norm you see in your communities? So maybe Gareth from the cleft you talked a bit about, but maybe expand on that. And Guchin, from your side, from the Eurodis perspective, is that norm the reality, or is it quite a different reality? Yeah, we can't hear you, Gareth. We can see you talking. I think the microphone's always useful.
Okay, yeah, it amplifies my voice. I think it's not the norm still, despite the work that's been done over the years. There is still a lot of clumsiness. I wouldn't necessarily call it malpractice. It's just people uninitiated in how to communicate well, not being aware so much. And we heard about this from one of my co-presenters. If you're a non-expert in a particular rare disease and you're the person who's actually giving the diagnosis, if for instance it's on a scan, you're a sonographer or someone, then you won't have the knowledge to actually give that information out. And I think that's a very difficult point. There's a lot of people in the front line in healthcare who will actually be the first one to suspect or say something. and they don't have the knowledge and the breadth of experience in communication to know what to do, or indeed to know where to refer on to. I think that's the biggest difficulty, is not having enough information at point of diagnosis or suspected diagnosis. It's the delay. In another part of that survey I did, we went on to ask, and when you finally reached the experts, the specialists in the team, were you satisfied then, or were you put more at ease? And in 90% of cases they were. So it's hard. How do you get information down the line to frontline health professionals, where you can't, you can educate them, I guess, at training schools, at university, to communicate better, but the actual precise knowledge they need to have, they need to know where to find it quickly.
I think, the information, the search for information, when you have all that uncertainty thrown into an uncertain world, we know that it's a bit of a double-edged sword, really. You want more and more and more, but by knowing more and more, it leads you up to more uncertainties or more options. I think with rare conditions, we have there's no sort of common pathway. Each condition evolves very uniquely to that individual, so it's hard to really tailor information. So I'll come back to the point about information being the key, and how that can be managed in an optimal way, because maybe more isn't the right thing, but it's access to timely and appropriate, and sensitive information. But your point around this isn't necessarily just an issue around the specialists who know the rare condition. This is an issue across the healthcare system with the non-specialists. Gülçin, I think we did a survey on Rare Barometer, and did that look at the non-specialist bit as well as the specialist, and what were the results?
Okay, so maybe I can give you like this picture of this reality a little bit by talking about the survey. So we recently published the results of this survey. That was some survey that we did within Eurordis to understand the journey that people living with a rare disease go through when looking for a diagnosis for their rare disease. We had 13,000 people from 42 countries join the survey, and they are people living with rare diseases, and their families, their caretakers participate into that survey. And the main result that came out of the survey was that an average time for diagnosis for people living with rare disease is 4.7 years. So it's a long process. And we know that there are many difficulties associated with looking for a diagnosis. So it is an isolating journey. It's a frustrating journey. And our survey showed us that 73% of them have been misdiagnosed at least one time. We also saw that patients go through many steps to reach for a diagnosis. So it can be like the online research and going from one professional to the other, having the test. So our survey also proved that by showing that people with rare diseases go through at least 8 or more visits, 23% of them, they go through at least 8 or more visits while looking for a diagnosis before they get their confirmation. So going through all these steps, diagnosis might look like it's the end of a search, but it's actually the start of another journey with possibly more steps. So I think we really need to understand better what people living with rare disease are going through, the background a little bit, in order to find ways to facilitate this journey. If you want to know more about this survey, I can send you the link. I really encourage you to take a look at that, and then we can talk about it a bit more later.
So that pathway, up to through all the different clinical services, non-specialists, is really important. And I think what you didn't add, but what I think you were, one of the key things I took away from it, which Jessie educated me on, it was really an epiphany moment for me, was when people are supported in a psychosocial way through the undiagnosed pathway, they actually get a diagnosis a year earlier.
Exactly.
So that support which Gareth was highlighting around when you see a non-specialist or you see people for tests, how you are talked to, how you're communicated to, can empower you to navigate a very difficult journey.
Yeah, for sure. I mean, community support is very important, not only when getting a diagnosis, but also looking for a diagnosis as well. So diagnosis is definitely very impactful in a way that it gives you the access to the community to look for better ways to support your child or yourself when going through this this process, for sure.
I'd like to bring in Andre really now, and you're a psychologist. You're in a very busy university hospital in the Netherlands. Can you share some of your experiences around how you've supported families in giving a diagnosis? Because it sounds like it's a process rather than a point in time.
Well, as a matter of fact, I think it's both, because for a lot of parents, especially the ones that already received the diagnosis, it feels like a point in time, and some of the times they forget what the 8 visits, as was pointed out by Gudrun, that preceded that, in our hospital, especially in the group in surgery where I do my research, so that's the Arnica side of my work. We do try to guide parents, even sometimes prenatally, because some of these, especially inborn disorders, can be diagnosed with ultrasound. So a lot of parents already know there's something going on, which is quite different from the genetic disorder population, which also has sometimes their diagnosis before children are born. But especially the group that is waiting for this really long, they have this point in time where they get the final message that this is going on. And it does matter when you already had the chance to discuss what could be going on, even when sometimes physicians are anxious to share this information, to share their hypotheses. We could say what we can see and what we expect or what we think it could be. In a lot of parents, they can deal with that. And that is, of course, insecurity. But we can't protect parents fully for that. And after this point of time, there's still a lot to do. And I think, as was addressed earlier, I think psychoeducation is one of the main things, because it's not only that, as Catherine said, you have the time needed, you need time to understand, but it's also what comes before that is to realize that you have something really serious that is lifelong or sometimes even life-limiting, which could become worse, and it is about me, or it is about my child, and that's in fact not a factual. It's not about the fact of the diagnosis, it's about the personal side of it, which is not the same as people being in denial. They're just getting used to, this is about me, or this is about my child, and this tells me something about what is going to happen to me in the near future.
Just to clarify, so that's psychoeducation, but that's for you, that's something you do with the families. You support them to understand things.
And we're starting up, because we do realize that, especially at an early age, parents and families can be really traumatized, which means also that there's a need to treat this trauma, this shock, the emotional part of it. But next to that, they also have a really huge need for information. So we're setting up some programs for that. And the ones that have been worked on most, I think, are the ones that come after the diagnosis. So, which tells you something about what does it mean for me? What does it mean to have a child with an intellectual disability or a mood disorder? What does it mean for parenting, education, future? It's always about, how does this make my future and my day-to-day life different, and what is to blame to my genetic diagnosis, and what is just about for instance, the 17-year-old adolescent? Is this about the girl with epilepsy, or is this about the girl with ADHD and autism? So to distinguish all these things, a lot of questions of parents come from that. I think psychoeducation could help a great deal.
We've just been doing some work on literature I think both of you are involved in, and that you know, whilst the condition really impacts on people's lives in terms of quality of life, our beliefs, our expectations, and how we see things is really what impacts on quality of life, and our beliefs and expectations are really shaped by these contacts with clinical services and wider in our community. So I want to go to Sarah, because you know you're one of our bright and brilliant, you know, medics in Reconnect, and you delivered diagnoses. You know, how do you guide someone through this process if there's no right approach, and where did you learn that if there's no training out there?
Thank you, Matt, for this question. Yes, indeed, we are talking about a process, and indeed it is a process. We can call it a process, and in every process, not all the elements come at the same time. So as doctor, we see patients with a story, but the story doesn't start with the first contact with the health system. For us, this is the part of the story, but not for the patients, not for the family member or for the caregiver. So first of all, we should, as doctor, as healthcare professional in general, we should take into consideration that the process doesn't start with our contact. The process starts with the early stage, the early onset of the disease, and we have to respect this part of the process that we don't know, listen for this part of the story that is important for taking into consideration an hypothesis, since for the healthcare system, the process starts with an hypothesis. For the patient and the family member starts with a story, with a bad story, with the onset of some signs and symptoms, probably in some cases not related to a definition of a diagnosis. For the healthcare system, the process starts with a contact, with a diagnosis, but in several cases with an hypothesis, so with elements of a differential diagnosis. And after this, we have to identify and try to collect the more information we can in order to confirm the hypothesis, or try to identify among the different differential diagnosis what we are thinking about. And the process doesn't stop with the diagnosis. The process continues in the monitoring. Even if we have a monitoring time, the follow-up time of a diagnosis, the process is still the same, since we have to check if all our explanation regarding the whole process, we should explain as doctors, not only the diagnosis, but this is my personal point of view. I think that it is really important during the follow-up, try to recap in which part of the process we are. Otherwise, it is a little bit confusing for patients, for family member and caregiver. So we should explain. The key word in this process is try to explain and inform the patients regarding all the part, all the stage, all the steps of this process. It's really important. And no, we do not learn this. We learn a lot of things in medical school, but we do not learn how to communicate this, how to explain in which part of the process we are. And I believe it is really important. I believe this as a person working in a European reference network, but also as doctors, first of all, since it's curious. I believe I'm a very empathetic person, but taking care of an heart attack, it is not a matter of attitude. And at the same time, explain something to a patient, to a family, it should not be considered as an attitude. It should be considered something that we have to learn as doctor, as well as taking care of an heart attack. So personal attitude should not be the way to communicate this. We have to learn, and probably we have to improve also how to learn in medical school or in other part of our education.
What strikes me is, your world is full of hypotheses and steps, and I think that point of disclosure, that's a traumatic event. In a way, when you see a car accident on the street, it's hard to sort of stay in a world of hypotheses and steps and to just be in the moment with someone. And I don't know who it was, but they said it's about being human. And I'm just wondering what are the barriers that we have in the system where that point of giving a diagnosis can't be more of human lived experience, as opposed to it being we've got more tests to do, we've not got enough time. What are the barriers really to giving a good diagnosis? And this is open to anyone.
Since we are talking about rare disease, one of the barriers in many cases is the knowledge regarding the rare diseases. But even if we have a lot of knowledge in different centers, one of the barriers could be to not to check all the possible hypotheses, since many of the signs and symptoms that patients have in rare disease, I'm a rheumatologist, so talking about systemic autoimmune disease, many of the signs and symptoms are symptoms common also to high prevalence disease or to no specific disease. So one of the barriers in many cases, besides the knowledge of rare disease in any case, is try to consider all the possible hypotheses. And this is one of the reasons we see during the evaluation a lot of patients with a long journey and a very big delay on the diagnosis, since many of the signs and symptoms that are common to other diseases have not been considered as a hypothesis of this differential diagnosis. So I think that is one of the barriers. And again, we come back to education of doctors.
Okay. But then again, we come to education in a second. Concha, have we got the results of the poll? How many people felt they had a good diagnosis or they experienced a good one? 10%. Well, if you say 4 and 5, that's 20. That's a quarter. So it's quite shocking that this is more the commonplace, is having it being done poorly, but maybe we're asking clinicians to do something which is impossible to do. I'm sorry, you were saying something, Andre.
Yeah, well, it wasn't about this part, but about something Sarah said. I do agree that information is one of our main core businesses. But then again, when I heard Gareth, he said most of the time it's not too much information. A lot of times it's not enough information, and I was wondering whether time isn't one of the main limitations. Because what I hear from parents who had a phone call stating their child had a certain syndrome, then I think, well, this is efficiency and the choice for doing a lot of calls in 1 hour, and things like waiting lists, caseloads, efficiency, they all limit, in fact, the room we make for not only answering and giving room for the questions, but also giving room to the reactions of parents, the emotional reactions they have, and to ask whether the point and the information even landed. So I think time is one of the main limitations.
I don't know whether it was, I don't know whether it was on a pre-call with one of you guys, But apart from time, there was something about feedback. I think it was one of the early speakers, not Caroline, Catherine. She was saying, giving the information, but asking, you know, is that okay? Is there anything else you need? And opening up the option for people to say, oh, this is what I think, you know. So I think it's time, but it's also being open for feedback in that process. I just wanted to connect the dots. Sorry, Gareth.
Yeah, I've certainly the issue is around time, but I think it's a very difficult thing for a clinician, perhaps, is to see the empathy or provide an empathetic approach, which is where we find a referral to someone who's had some training, but another person who's gone along the same journey with a rare disease can be so helpful in actually adding that bit of empathy. The clinician can provide the facts, they can communicate hopefully relatively well, but I think you need someone who can provide some empathy as well. I think that really helps.
I love that, and I think that touches on earlier the point about referring and connecting someone to a patient organisation, which isn't done as standard, if I understand that right. Is that right, Guchin? How many people? I'm sure you have facts and figures on that.
Yeah. No, I actually wanted to talk about a study that we participated partly, but it is showing the importance of how patient organizations can really improve this process, because it is a process called experience-based co-design, and it is, I think, very relevant to our topic. It's a study on healthcare services and how they need to be improved in a way that they deliver the results of the genetic testing to the rare disease patients. And they use this co-design methodology, and they were in together with the families and the staff of people that are included in the genetics testing services, like the doctors and nurses. And they identify different areas of like where they are providing services. And they conducted the interviews with doctors and nurses and patients. And once the interviews were done, they came together as groups and shared what are their priorities for improving the communication around the giving the results of this genetic testing. And they did it like more than one time. And I think the important thing of this study is that this can be done like by including patients, their caregivers, and the priorities were like they have found similar priorities. Like they found that post-test care is very important for both patients and professionals, and they definitely needed a follow-up for the doctors to be able to give more information to answer the questions, and for the patients to be able to ask what is in their mind. And then also they found, as you said, the psychological support, the community support was very important. And I think this kind of study is giving a lot of information on what can be improved and how patient organizations can really be included actively in this type of studies. But more importantly, how can collaboration between key actors can be achieved? Like, so it's not really by saying it. Yeah.
You've really stimulated my mind. You know, there's evidence. It's clear that when satisfaction and patient experience is a proxy to is a measure for demonstrating quality and efficacy of services, that's been proven. So if you say, oh, my care was good, the outcomes to care was good, they've demonstrated that in cancer. So I just think, you know, asking, you know, you give a diagnosis to a family, say, oh, could you complete this survey on whether, you know, the service you received was good or not, get that direct feedback, and it probably would be, this has been terrible. So I think maybe that feedback loop of some type, maybe not formal, like, you know, it wouldn't be appropriate, but asking, I think it was Catherine had highlighted it, once you're given that diagnosis, asking for feedback, is there anything else we can do? Giving that opportunity, I think, brings people in to giving a sense of control. So it really strikes me from what you say, Guchin. I don't know, you want to
And
come back?
it's not only the feedback, but it's also like including the patients in every step of the way. We always say
Yeah.
that in research, we want the patients to be included from the beginning of research. And this is this type of the research that we're looking for. So we really want them in the design, in the methodology, and then throughout the research study to be able to have more impactful studies that will be used in the end by the people who need them.
I put the results on. I didn't share them earlier, so that's I'll stop sharing in a minute. But that shows only 24% of people scored 4 or 5 were happy that the diagnosis was given well, which I think supports some of the points you were making, Gareth and Catherine and Guchin. I'm going to stop that. I'm terrible at chairing the time on this, so I want to see, Concha, is there any questions from the Q&A which we've seen, or if anyone wants to raise their hand and ask a question to Sarah, Andre, Guchin, and Gareth, or in fact any of the speakers from before?
I can see a hand raised from from Mustafa, so I'm gonna allow him to talk.
Thank you. Mustafa?
Maybe it was
No.
an involuntary thing.
Okay.
Okay.
Is there any other questions in the chat? Or if anyone wants to raise a question, raise their hand. No? Okay. So I'm going to, we've got about 10 minutes left. So I want to ask everyone, and also I bring in people who spoke earlier, Marizella, Anna Meta, Caroline, and Catherine. So there's obviously barriers around time, around having a lack of knowledge, or to be able to give, focusing on checking hypotheses, and really needing to. Those are some barriers which we identified. How do we solve them? How can we skill up our existing workforce to do something which the education system aren't doing? I know we've had some good examples from the ERNs, but what can we take away as all 24 ERNs? I don't know if someone wants to come in, it's open.
If I may.
Yeah.
We should consider that we have different level of communication that we may give to the patient. I agree that time is a barrier, but since we have 2 different levels, we should give all the information in a very short time during the evaluation, okay? But we should not perform patient education during the visit. We may deliver pieces of education, and time is not a barrier for having a good communication, even if short. But
Okay.
when we believe that patient education outside of the evaluation with the doctor is important, personally I consider it very, very important, we have to organize patient education regarding a specific disease. I had this feedback from a patient education that we launched on a specific disease, and patients performing patient education, not during the visit, in another room, in other time, the communication is really, really better, and their mental impact for the disease is better than without patient education. So we have to communicate good during the visit, and a personal attitude should not be the way. We should always communicate good what we have to communicate during the visit, but in many, many cases, patient education outside the visit, the evaluation is really important to fight against the burden of disease, of the mental burden also of the disease, the diagnosis.
May
Thank
I
you,
add to
Sarah.
that,
Yeah,
Matt? Yeah.
yeah, absolutely.
Yeah, I do agree what you said before. It's not only an attitude, and you can learn this. And I agree that even if it's short, it can be a good conversation. But I think what is necessary for the healthcare provider to be open and curious to these kinds of reactions. Sometimes that's even mirrored by patients and parents. If you're open and curious, they are as well. So you need to ask things like, did you recognize parts of this story? I was talking for a long time. Sorry about that. How was it to hear all this? Or some parents get angry or sad if they hear their child has this or that. What came up when you heard me talking about this? So we really need to ask the right questions to find what's going on in the minds of parents during this session of giving this sensitive information.
So I'm going to be a bit naughty. I want to put all the psychologists on the spot, so that, you know, I think Anameta just jumped out of the room, but I think the other ones from Cranio, from Vascern, and from Rare Eye, could we, as an output of this webinar, come up with a sort of a helpful questions or approach in terms of, you know, what you're saying, Andrea, you know, mirroring, so setting an example of being open and asking, is there something we can do, like a crib sheet from this?
You want to have it quick and dirty.
I want it quick and dirty. I think quick and dirty is good.
Yeah,
we can refine it along the way, but I don't know.
I think we could do with that, but I'm not
Yeah.
sure.
Yeah, of course we could have, you know, how do you formulate a question or how do you formulate things? But there's other things as well in the communication. There's body language, and that is also a training thing. Also observe what you see, because I think what Gareth mentioned in this survey, some of them think it's too little. Some people think it's too much information, and that is, I think, connected to people are different, and how you deliver something and communicate is by also not only asking the questions verbally, it's also by observing the reaction of the body when we're talking. How detailed should I be as a doctor or surgeon talking about a surgery? For instance, some of them want details. Some patients want to know in detail. Some of them are fine just knowing, okay, what area is the surgery going to be performed on the body. So there's a lot of other things also to consider when communicating. So not only what we say, it's also everything else that is happening in the room.
So as a concrete outcome from this webinar, I think it would be at least really good to connect the psychologists who are active in the different ERNs together and to start sharing ideas and seeing what we can develop. Because I accept what you said, Andre, that, you know, this is quite complex as well. But I just wanted to have an action, because it feels like we need to move forward together. And there's all situations are unique, as it were. And I can see Lucy's very active in the chat, and we can maybe connect the across ERN psychologists with Medics for Rare Diseases and see how that can help with building some of the training in those, you know, junior doctors to bring things forward. I'm conscious we've only got 1 minute left, so I just want to go round, and I'll include Caroline and Elizabeth as well, and Catherine. I wanted my last question is one take-home message. What is the one tip you would say is you want to recommend we should do to improve diagnoses being given? So I'm going to do ladies first, whilst Elizabeth's thinking, because that's your thinking face, Elizabeth.
Could you say again
Repeat
your
the question. Okay.
Yeah, repeat the question. I didn't really understand it.
So from your experiences, all your experiences, what's the one thing you want to recommend as a take-home message that that we should do to improve how diagnosis is communicated? So Gareth's thinking as well, long and hard, and so is
Yeah.
Catherine. So I'm going to start with Marizella because you look like you're ready.
Perhaps I'm not, well, just
I'll
like
come to you.
this.
Yeah, yeah. Go on then,
Perhaps I
Elizabeth.
think what's important is to have different different medical professional to talk with. For example, for us, the professor told that that was the diagnosis,
Mhm.
but he also told us that we could meet the psychologist.
Okay.
And I think that's important because it's not the same thing. It's
Yeah.
not the same approach. And even if it's another doctor, that's not a problem, I think. But I think having different approaches is
Okay.
important.
Brilliant. I'm going to move on because we're going to run out
Yeah.
of time. So Marizella, you go.
I read the chat while you were talking. So the question was about
What's the one
just-
thing you would recommend as a take-home message on how to the best thing to improve how diagnosis is given?
I would like to mention another. I mentioned one thing during the presentation, and I think it's really important when it's rare disease, it's limited information and uncertainty. I think what's really important is the availability. You need to be available as an expert center or healthcare professional working with that diagnosis, because that is one way of being available for questions, for repeated information, for new things that you have discovered about the rare diagnosis. So availability
Brilliant.
is really important.
Perfect. Thank you very much.
Thank you.
Andre.
In addition to what I already said, that
Yeah.
that I think openness and curiosity is one, and I do think it's worthwhile thinking about the questions for conveying a diagnosis. I think nothing about them without them also means that we need the medical doctors to think along with us in how to improve this process and to give suggestions for the right questions at that in that conversation.
Brilliant. I think those were 3 points, not one, but I'll let you have
Sorry.
it. Sarah. No, it's fine. I won't hold it against you. Sarah, from you.
Yes, for me, try to, from the healthcare professional point of view, try to communicate in the best way we can, and more important, check if people understood what we have explained and what about we have informed. Otherwise, this is only one-way communication. We have always check what they receive it as information.
Brilliant. And I love that time doesn't impact on quality of communication. That's the one. I want to get a t-shirt with that on. Catherine, from you. Oh, you're on mute.
I think it's important to organize the diagnosis. It's not one time, it's not one shot. So multimodal organization with different professionals, it's not what time the given the diagnosis, it's not one shot. It's multimodal with multiple different professions, and after follow and be available for any question. So it's a way of organization, I think, and be open, of course.
Thank you. Caroline, are you still there? Yep.
Yeah. So I'm not a doctor, so it's difficult for me to give something from my experience. But I would advise to play with our game, and I just wanted to say that it's not only for rare eye diseases, but it's really for all rare diseases. So you can really play as a clinician in any kind of rare diseases.
I love your game is serious. That's great. Guchin, from you.
Yeah, I think we need to bring all stakeholders into the conversation, training of doctors, nurses, and also other healthcare professionals by patient organizations. And I think we have a lot of input to give, but also we need to find out how things work in practice and manage expectations and also priorities and tailor them according to different types of diagnosis, different cultures, and even for different generations, I guess.
Brilliant. Last but not least, I was leaving the patient voice to you, Gareth. So
very brief. I think we need to get across a sense of one human being conveying information to another human being.
brilliant.
Mhm.
So I think we're a bit over. Bad timing, chairmanship by me. I wanted to thank, I think I covered everyone who was in the discussions and the presentations as well to contribute to the end. I want to thank everyone for contributing today on the call, on the webinar. We've got a very lively chat, and I think I'll definitely connect with Medics for Rare Diseases to see how we can move forward on the medical education side. I think that's really great. And I wanted to thank Concha for opening the webinar. I'm sorry I wasn't here at the beginning, but I look forward to continue this discussion, bringing together the psychologists from all the different ERNs. So thank you very much, everyone. Wishing you all a nice rest of the day.
Thank you. Bye-bye.
Thank you.
Thank you. Bye.
Bye.
Thanks.
Thank you.